Alrighty, everybody. Welcome to your latest video in service. I hope you get to enjoy this from home in your pajamas. We are going to cover ketamine and the sedation policy. And there have been a few changes to both policies in the last year, but of course, something else happened in 2020. Can't remember what, kept us a little distracted. So I thought we would go over it now. Alrighty, so just as a refresher, when we talk about sedation, there is moderate sedation or conscious sedation, where the patient still maintains their airway, their breathing's adequate, and they should be able to respond to tactile or verbal stimulation. There's also deep sedation, where their ventilation might be impaired, they might require an intervention or so, but they can still respond to painful stimulation. Per the institution policy, propofol and etomidate are considered deep sedation, whereas some of our other medications that we give are usually associated with moderate sedation, like Versed or ketamine. The two policies that we are going to go over are the HHS procedural sedation policy and then the ketamine policy, which is ER specific. So just as a reminder, when we're getting ready for sedation, we are going to be completely prepared. We're bringing that crash cart. The ambu bag has to be out of the bag, hooked up to the wall and ready to go. We have our suction, oxygen, patients on end tidal. We have our fluids ready to go if needed, your meds, your reversal agents. And again, all of this preparation is part of our policy, right? How we prepare to sedate somebody. Also for the institutional policy, so only certain physicians can provide deep sedation, and one of them being, of course, our ER attendings. And again, per this policy, the ER physician needs to administer or directly instruct the administration of deep sedating drugs to the RN while controlling the airway. So when we do procedures that require sedation, there's one physician that's in charge of the procedure itself, and then there's one physician that's in charge of the sedation. The doc that's usually in charge of the sedation is usually the ER attending, but if they are at the head of the bed or managing the airway or involved, we can still administer the medications for them in this setting. So of course, every doc's favorite drug here is good old ketamine. So ketamine does a lot of different things depending on the dosing that is given. You know, it can be used for pain control or analgesia. It can cause amnesia and sedation in a dissociative state. It can also be used for deeper sedation, like for induction for RSI. So again, all of this is dependent on the dosing that is given to the patient. So we are, and again, this is from the ER ketamine policy. So we are familiar with giving IM ketamine. It's a much higher dose, more to 4 to 5 mg per kg. You don't necessarily need IV access to give IM ketamine. It should kick in about 5 minutes and last for around half an hour. Now, giving IV ketamine, depending on what we're using it for, is around 1 to 2 mg per kg. We are giving it over 1 minute. And it should kick in within a minute, and that dissociative effect should last around 10 minutes. Now, once we give the first dose, we can give additional doses or boosters, usually smaller doses, to get that patient to the right sedation level that we want. So again, your IM ketamine around 4 to 5 mg per kg, kicks in 5 minutes, lasts for half an hour. When we're giving IV ketamine, it'll kick in within a minute, should last about 5 to 10. And the ketamine policy for the ER covers ketamine for sedation or dissociation and induction. It doesn't necessarily cover the analgesia or the pain dose ketamine, which is separate. We're talking about when we give ketamine for sedation or for induction, like an RSI. So when you're giving the ketamine, you have to push it over 60 seconds. A big reason why our docs like ketamine is because it doesn't impact the airway the way that a lot of opiates or other deep sedating medications do, like etomidate or propofol. But if it is given too rapidly initially, it can cause a short period of apnea and a poor cough or gag reflex. So it really needs to be pushed over 1 minute. Other important things to know about ketamine is, of course, the side effects. So as we all know, vitamin K or party K, it can be used as a recreational drug for those dissociative effects. But the side effects that are very common that we see include drooling, Twitching or nystagmus, that eye twitching. Your patient may become hypertensive, or if they already were hypertensive, they're going to be more so. They may vomit when they're recovering. And then about 17% of patients are going to have recovery agitation, also known as a bad trip. So because ketamine can be kind of psychedelic, so to speak, we want to prepare our patients before they receive ketamine, and also prepare the environment as they're recovering from ketamine. So, low stimulation, low lights, generally in a quiet area, if you can find a quiet area in this department. And most patients are going to have to be verbally redirected until they start metabolizing this ketamine through, if they're having that recovery agitation. About 1 to 2% of the time, you'll have somebody who's extremely agitated and is going to require a lot more intervention to calm down after having ketamine. And it's worth it to note that one big contraindication to ketamine is somebody who has psychosis, right? Who's not going to handle a drug like this well. And we generally avoid it in that case. So when you are getting ready to give ketamine, as of right now, there are 2 different types of concentrations that are stored in our Pyxis, and they're labeled under intravenous and intramuscular. The reason being that one type of ketamine is far more concentrated than the other. This is obviously, especially when we're overriding, right? We're overriding, this is urgent, we got to go. Very easy to pull the wrong one, and very prone to med errors. So just like with any high alert, high risk drug, you are independently double checking the medication, the dose, the concentration, and the amount before we're administering this to a patient. Coming soon is we're going to have pre-filled ketamine syringes, which should make wasting ketamine a lot easier, and hopefully the med error, the risk of a med error much lower, because it's going to be obvious that this is for IV. So that should come in within the month, and I'll let you know when it's actually here. So let's say we're going to sedate a 2-year-old for a complex lac repair. When we're preparing for sedation, we're doing our usual, we're getting all the supplies at the bedside. We have to make sure the patient or the parent is consented for the sedation as well as the procedure. In emergent situations, that consent can be obtained verbally, that's fine. You want to make sure you teach the patient or the parents what to expect. If we're going to be giving the kid ketamine, we want the parents to know if the kid starts twitching, or if their eyes start twitching, or they start drooling, that's normal, right? That the child may have their eyes open and look like they're awake, but they're really not, right? They're in that quote unquote disassociated phase, and they're probably not going to remember anything that's happened. Before we start any procedure, we're getting that baseline Aldrete score. And this is important because our patient has to come back to their baseline before we can stop our monitoring after the sedation is over. So patient's totally hooked up, everybody's at the bedside. We do not administer any medications until the doc is ready, right? That eye-to-eye contact, we're ready to go. It's just like when we RSI a patient to intubate. We are not giving medications until everyone is set up and ready to go. Once the sedation begins, this quick bar again is part of your sedation narrator. We're doing vital signs, the end tidal CO2, and the level of consciousness every 5 minutes. And I'm just going to put it out there again. So with ketamine, your patient might still have their eyes open and look like they're looking at the ceiling, but the reality is they're disassociated, and thus their level of consciousness is sedated. So when can I stop this every 5 minutes monitoring? Again, this is per your hospital-wide, enterprise-wide policy. We are monitoring that patient every 5 minutes, even after the procedure's done. If ortho's done, reducing the fracture, whatever procedure we're doing, it is still every 5 minutes until that patient is awake and can talk to you if they're able. At that time, once that patient is awake, then it's every 15 minutes until they meet discharge criteria. Discharge criteria meaning their Aldrete score is back to baseline, they have no respiratory distress, their protective reflexes are intact, they're not nauseous, vomiting, dizzy, and it's been at least 30 minutes since the last medication they received. That would be 4 hours if we had to reverse them. So that is your discharge criteria. That's when you don't have to do vital signs every 15 minutes anymore. All right, every 5 minutes until they are awake, and then it's every 15 minutes until they're no longer dizzy, no longer nauseous or puking, and their Aldredi is back to baseline. Now, when we want to discharge these patients home, we can discharge them home if they have a responsible adult within 30 minutes of them receiving a medication. However, the doctor, the ER attending, must eyeball and see the patient before they go. If you have a patient who doesn't have a ride or a family member, we have to observe them for 3 hours before we put them on a taxi to get them back home. Alrighty, so I hope you guys enjoyed this very quick review of sedation and what our current policies are between that, ketamine, and other medications. If you have any questions, as always, you can hit me up. But I hope this helps you feel a little bit more comfortable. And that's it. Thank you, guys. I can stop the recording. Thank you.